next speaker will be Dr. Arun Mistry, providing an update on Leriglitazone.
Good afternoon. Um, we're going to be keeping you away from your coffee because I think that's going to be coming next after this. So it's coming soon. First of all, thank you very much for inviting us to provide an update. Today's session for us is myself giving 10 minutes of some updates for the whole program, and then Dr. Mussolino giving an update specifically for some pediatric data that's come through earlier this year. So my name's Arun Mistry. I'm the Chief Medical Officer at Minoryx. I've been there for about a year, so I was here at the Baltimore meeting for learning, and I'm still learning a lot about ALD. So very briefly about Minoryx. Minoryx is a very small company, but founded in 2011. We've just had our 12th birthday. Um, two small offices, one in Spain in Barcelona and one in Belgium. And what we have is a development program looking at rare diseases, rare neurological diseases with an unmet need, really focused on one molecule called leriglitazone, which I think you've been hearing about during the data. So just very quickly about leriglitazone, what is it and why are we investigating this? This is a molecule which is an oral molecule, so not a gene therapy. It's really just a suspension that is given orally, and it's a brain penetrant. So it's a molecule that from the bloodstream can actually go through towards the brain and is acting on the brain in terms of specifically looking at inflammation, looking at myelination in terms of reducing demyelination and possibly promoting some myelination, which is the sheath around the axons. And then also improving the mitochondrial function, which I think you've been hearing about from the brilliant work from Alice on the Drosophila as well in terms of the antioxidative effect. The lead area that we're investigating is ALD. And we're looking at this together with bringing this product to the marketplace. So we're in dialogue with the EMA, which is the European Medicines Agency, and actually have the product under review for licensing and an approval in Europe at the moment. And with the FDA, we also have very positive dialogue and a pathway looking at a phase 3 program, which is something I'll talk about shortly in adult cerebral LD. We've got good communications with the regulators. We have orphan designation, and which means that we can actually sort of have a lot more dialogue with them, help and support from them. We have the rare pediatric disease designation, which again gives us much more dialogue opportunities with the FDA as well. Also, leriglitazone, with its multiple modes of action, has the opportunity of looking at other CNS diseases. We've looked at and investigated Friedreich's ataxia in a small study, and we're looking at other potential indications as well in CNS. And then just finally, in terms of, we're a very small company, we're about 27 people in total globally. So we look for partners and in Europe for future commercialization because we're possibly close to an approval. We have a partner in Neurac Farm, and they will be launching the product for us. And then Spain, we have in China, we have a partnership with a company called Spherogenics, and they will be supporting any development and commercialization. So, I'm going to be talking about three studies. But first of all, the Nexus study, which I won't talk too much about. This is what Mussolino will provide an update on. A study called Advance, which I think you've all heard about in the years that have gone through, which is a study in adult AMN men. And the results were actually published earlier this year in the Lancet Neurology. So briefly touch upon that. Again, gives us signals to why we're doing the next phase of work in the US with the CALIC study. And that's the final study that will come on to. So, really, just looking at the advanced study, one of the key outcomes of the study that we saw was a reduced incidence of cerebral lesion progression, which was one of the endpoints of the study. This was an interesting finding, but it was an a priori um, part of the study in terms of efficacy assessment to look at serial MRI scans to check for any progression of the size of the lesions or the less score of the lesions. And what we saw in the whole population was only 3 patients out of 77 in the active arm in the double blind period. There was progression of cerebral lesions. However, there were 8 patients in the placebo arm who progressed. So again, this is something that was very see. This was all read by central readers. It wasn't just a local read of the MRI scans. So very controlled as to how this. Again, that data actually sort of supports and is a surrogate for the actual diagnosis of clinical cerebral disease and cerebral ALD in terms of rapidly progressive disease that we all talk about. And what we saw from that, and that was reported as a safety finding, as a serious adverse event in terms of this was a key medically important finding that the investigators at the site were noting down. What we saw from that data was that there were no patients in the active leriglitazone arm who developed active raw ALD. However, there were 6 patients in the placebo arm who, in that 2-year period, developed ALD. So this is a key finding that we saw 2 years. We're just going through the open label extension of another 3 years of treatment in all patients from active and placebo receiving leriglitazone. And we have some interesting findings that these data are consistent with this 3-year data as well in terms of maintaining that reduced. And then just want to touch upon some of the AMN aspect because we all talk about the devastating aspect of CALD, but AMN is quite an important um, problem that we want to help manage. We know that balance is a key um, problematic problem. We wanted to assess that, and that was assessed during the course of the advanced study with force plate analysis. And what we saw was looking at body sway, we saw actually over that 2-year period a small improvement with body sway plate for the active group and a worsening, which would be expected for a progressive disease, in the placebo group. Again, what we starting to see in the open label extension study, another 3 years of treatment, is the placebo group actually has this small improvement for 2 years, then stabilizes, and the active group continues with that stabilization. So again, very important data that we're starting to see in the open label and consistent. And then really sort of thinking about which patients are going to benefit most from especially daily active living balance, improved or reduced in progression in the whole population of the advanced patients that we enrolled into the study. But in terms of the ambulation, in terms of walk test, ESS, all of those sorts of regulatory parameters, what we started seeing through the course of the study also was reported by the Amsterdam group was that patients who had less than 10 years of symptoms of AMN were actually sort of deteriorating faster than patients who had more than 10 years of symptoms of AMN. So really those patients in the first 10 years have more problems and progressive problems than the patients who are less ambulatory after 10 years, which is quite an important sort of part of the natural history, which helped us understand a little bit more as to how should we start looking at the data. So as a sort of post hoc analysis, we looked at the early AMN patients and we started seeing that patients in the early AMN portion on the active treatment really have significant reduction in compared to placebo. So again, looking at the early AMN population is going to be quite important for understanding ambulation. And then one other piece of information that we sort of started seeing as to why we're doing the next phase of the development program is in Europe we have compassionate use program, both in adult and pediatric. Um, we have around 30 patients where we have received reports back so far from the prescribing centres as to how the patients have responded. We've got to take into consideration that this is not a clinical trial. This is really just reports back patient by patient as to how they're responding. Also, the patients that enrolled into this compassionate use program very heterogeneous. Some patients have got early disease, some patients have got advanced disease, and diagnosed both clinically early or advanced, or radiologically with a less score of early or advanced. But what we're seeing is patients with some gadolinium enhancing lesions are converting back to not having enhancing lesions. We're seeing stabilization over a 6-month period in lesion growth in these patients as well with serial MRIs. Um, it's really sort of given us this feeling of something is happening, investigate further. Together with the data from the next study, data that's coming out from the advanced study, we feel very confident to progress, get more data. We're going to be doing with the Helix study, which I'll move on to now. The Helix study, the study that started in America, US, we have 5 active sites at the moment, and the study in adult CALD. This is adult CALD where stem cell transplant is not an option anymore, or the patient is refusing. Adult patients are often not eligible for stem cell transplant because of the advanced AMN disease, but got Dr. Lund here to explain more on those things than I can explain. But there's reasons why patients have chosen, adult patients have chosen stem cell transplant. It's important that that is discussed. We're going to be looking for 40 patients in this study, and it's a placebo-controlled study running in the US and Latin America, in Argentina and Brazil. We'll have 8 centers. Got 5 centers set up already in North America. We'll have one more, and then 2 centers in America. We're looking at primary endpoint survival. So it's a placebo-controlled study where 20 patients will receive litifilimab and placebo. This is a study that's been discussed and agreed and approved by the FDA. What we're going to be trying to do, really importantly, is trying to bring enrollment in as quickly as possible. So the good news, with the support of the community here, the community from ALD Alliance, and also the community from ULF, is that the study is starting to be understood and known. We have the first patient randomized last week. The second patient will be randomized next week, both in Minnesota. But we have real need to try and condense the enrollment. The reason for trying to condense the enrollment, as you can see from this graphic, which is quite small, is that there are actually options at 18 months. Once we've got the last patient, it's 18 months of doing a full interim analysis. And if we're successful at that interim analysis, all patients, including placebo patients, will move on to the active arm of the study. So we really want to sort of try and bring many patients in as quickly as possible. That interim can be repeated if it's not successful at 27 months. And the study in total is duration of 36 months. But if we can get success at 18 months, that's, much better for the patient community to get an answer and to really move on with getting the product through the regulatory path. In terms of where the centers are, again, they're the typical centers. So we have Baltimore with KKI, Boston, as I've said, Minnesota, Utah with Dr. Bonkowski. We've got Stanford with Dr. Van Heron and Jacinta Sampson. We also have a new center in Florida, which is going to be starting hopefully in the next month or two. And I think this is, a really good win for the community that there'll be another center that will start becoming more expert in managing larger numbers of ALD and AMN patients. And then we have two centers, one in uh, Argentina, one in Brazil. One important point I'd like to stress is that we actually have called a pre-screening campaign. We have a pre-screening campaign for looking at MRIs and genetic testing, supporting early diagnosis of patients who may have CALD. We know the adult AMN patients are typically not always in routine care, not having serial MRIs, especially as they get older. We want to help support that early diagnosis by getting patients through an early pre-screening program. So there is a website, so cld-study.com, and that study actually that website does a pre-screening form, and if patients are identified through either family members or patients themselves who may be eligible, they are referred to one of the centers that are open as part of a consent process, doing an MRI, doing genetic testing, in a sense, really getting them understood if they're appropriate for the study or not. This is something that is happening already. We've had over 140 submissions onto the website. We actually had to have a pause because there was too many submissions to the website before the centers got going. But we'd really like to sort of generate much more activity on the website again, and with the help of the community. We also have all the sites looking at their own databases, and we've got more than 20 patients sort of going through that system locally in each of the centers as well. So really appreciate all the support from the centers, the families, uh, to get this going. In terms of the inclusion criteria, I think that there's one key inclusion criteria that is important. I think I've already spoken about patients not being eligible for stem cell transplant or not wanting to proceed to that. And then the other one really is having a less score of less than 12. So we heard earlier when patients have got advanced disease, and what we've seen through the compassionate use program in Europe is once there's advanced disease with a less score of greater than 12, we're really seeing patients still progressing because they have a lesion load. That lesion load is always going to have a clinical impact, and we can't reverse, the product doesn't reverse that lesion. It stops that lesion progressing, but the damage is there. So that's a key element of the inclusion criteria. We we will allow patients to come in who are wheelchair bound. We're looking at MFDs, as was being described before, in terms of major functional disabilities as one of the other endpoints. But we know AMN patients are sometimes wheelchair bound, or they have incontinence problems. They're allowed into the study, so that's not an exclusion. So thank you very much, and a big thank you to ALD Connect for you know supporting all of the programs that we're involved in, but also to ALD Alliance and the ULF, who've been helping with bringing an understanding of the studies that we're running and sharing information about. I think with that, I'm going to pass on to Dr. Mussolino
Real quick, we're going to actually do some
Are we?
questions,
Okay.
and then we're going to take a break because ALD Connect listens. We heard some people wanted to take a quick break. So let's start with questions, and then we'll come back to Patty.
Thank you very much for your presentation. On the last slide, it was talking about inclusion criteria. One of them says have a normal adrenal function. Does that mean any man with AMN or CALD who has primary adrenal insufficiency is not a candidate?
No. So normal adrenal function, we mean if it's supplemented by steroids and you have stability, that's fine. So it's not an exclusion if you have adrenal insufficiency. As long as it's managed, it's fine.
That's great. Thank you.
No, good question.
Yeah, I was just wondering why you wouldn't give the Leriglitazone to adults who will receive the stem cell transplantation as an add-on therapy.
So